Hey, welcome back, everybody. Time once again for our episode we call Living Hope, Your Journey with Pancreatic Cancer. Where today we're going to give you some updates and some information from the woman who seems to be on top of all of it, Roberta Luna. Welcome, Roberta.
Thank you. I don't know how much on top I am, but I certainly find that I'm learning something different every time. So I'm very thankful for that. So thank you. Today we have Cindy Gavin, CEO and co-founder of Let's Win Pancreatic Cancer, joining us, as well as Dr. Shariff, the co-founder of Citrus Oncology and associate professor at Duke University. Thank you, ladies, for joining us. I want to get going on this because there's a lot of important information we want to try to cover, and it's very difficult to do it in a short period of time. But thank you for joining us. We do appreciate it. Dr. Shariff, can you explain the connection between diabetes and pancreatic cancer?
Yeah, absolutely. I think, when I think of diabetes and pancreatic cancer, I'm thinking about the fact that the pancreas is the factory that makes insulin. And if you have cancer that is affecting that factory, the production of insulin goes down. And when the production of insulin goes down, it unmasks something called diabetes. And there are different kinds of diabetes that patients with pancreatic cancer can have, where they have insulin deficiency or they're just not able to make enough insulin to match the needs of the body. So this is a very common and a very big problem that pancreatic cancer patients face. Individuals with pancreatic cancer, about 50 to 80% of them are going to have some or the other whiff of diabetes or something that we call impaired glucose tolerance, even prior to them being diagnosed with diabetes. And about 85% of those folks actually have diabetes in the course of at the time of diagnosis or between them getting that diagnosis and having their treatment within the first 2 years. So it is a big problem, and it is a common problem. And it makes a lot of sense because the factory that makes insulin is the one that gets impacted by pancreatic cancer.
Do you think does one condition influence the other?
Yes, there are studies that actually underline and underscore the association of diabetes and pancreatic cancer. So they go hand in glove when it comes to not only the development of pancreatic cancer, but also the result of pancreatic cancer. So diabetes is something that I call it as an amoeba when it comes to pancreatic cancer. It really fits into multiple nooks and crannies, right from the beginnings of pancreatic cancer to the time it is diagnosed as one of the precursors or things that get diagnosed even before you get pancreatic cancer, and occurs as a result of pancreatic cancer itself.
So then does new onset diabetes serve as a potential early warning sign for pancreatic cancer?
Absolutely. In the right patient population and the right context, it makes a lot of sense. But the thing is that when people get diagnosed, diabetes being such a common condition in the general population, right? And weight loss coming from diabetes and the symptoms that occur with diabetes can overlap significantly with the ones that come with pancreatic cancer. For example, if someone has new onset diabetes, their A1C is higher, their blood sugar is higher, and they lose weight, and they're not able to eat as much, they're going to the bathroom a lot. These symptoms can be very similar to pancreatic cancer as well, because you can have diabetes coming from pancreatic cancer. You can have weight loss coming from pancreatic cancer as well. So oftentimes, it is not the first thing that physicians and providers are thinking about, because they're putting patients in that bucket of, oh, this is run-of-the-mill type 2 diabetes that occurs in the general population, whereas about 1% of that diabetes is coming from pancreatic cancer. So you really have to look at the patient from the whole person approach and try to understand that, hey, I'm trying to fix their diabetes, and despite that, they're losing weight. That is not normal. That is not normal. When people's A1Cs go down and they're getting insulin, their weight is supposed to go up. And despite that, if their weight is staying lower, that is something that needs to be looked at in a more granular fashion. They have to look at it with a different lens in order to identify pancreatic cancer. But it is one of those things that occurs commonly when, as a hindsight, when you look at it, oh, wow, I did have diabetes. But does every patient with diabetes have pancreatic cancer? No. But a lot of patients with pancreatic cancer have diabetes. So it's a hindsight 2020 approach when we look at it. But patients have to be listened to and heard when it comes to, I'm having 30 pounds of weight loss in the last 3 months. I'm not able to eat. My stomach's filling up. I'm having loose stools. It's the combination of symptoms that really drives you towards a diagnosis of pancreatic cancer versus just general diabetes. So that is something that providers and physicians need to listen to their patients and ask those additional questions to put them in the right bucket.
So I'll just jump in and say, Let's Win really is here to guide patients and families that are not only recently diagnosed with pancreatic cancer or living with the disease, but also to get ahead of the disease. So to understand those that are at higher risk, we have a dedicated section to demonstrate the link between pancreatic cancer and diabetes. And this is not to pump fear in the system. It's really just to raise awareness and educate it. And in that section, we have a quiz that helps patients answer questions about whether or not they are at risk to share with their doctor, and also different medically vetted stories in English and Spanish illustrating the link between the two.
So I know it's difficult just to, get the doctor to consider even pancreatic cancer when you have symptoms, and now to add, diabetes to it. What is the best way the patient and their family can be their best advocate in getting this done?
I think the best way to advocate for this is to raise that concern and that question. I think doctors are not thinking, or providers are not thinking, because they're focused on fixing the diabetes. When you tell them, hey, my diabetes is not like the usual diabetes. I'm losing weight. I'm not feeling great. I just feel extremely tired. This is unusual, and I've lost weight in X amount of time, right? That is something that, or I had well-controlled diabetes, and in the last month, my A1C just jumped up from 8% or 6% to now 9% or 10%. That is not normal. I'm not doing something different. I'm not eating differently. I'm not exercising more. I'm not exercising less. I'm not eating out a lot. I cannot explain the increase in my blood sugars, because what happens in a busy clinic is that we're trying to make these assumptions about, oh, this may be the reason, this may be the reason, right? When patients and families advocate and say that, hey, I'm losing weight, I'm not eating differently, I'm not doing this, my A1C is going up despite me losing weight and me eating the same kind of food or lesser even because I just don't feel like eating. That should really change the perspective of the person sitting in front of them, because that's not normal. A1Cs go up when people eat more. They're eating unhealthy, they're drinking lots of sodas and juices, they're gaining weight, and they're having all these other issues with it, right? So they tell you that, hey, my lifestyle's different, or I just, I stopped doing what I used to do. I stopped exercising. I stopped focusing on my diet. That story adds up with worsening diabetes. The other one that I just told you, that I'm eating just the same, in fact, I'm not eating as much, and still my A1C is going up and I'm losing weight. That combination of symptoms should really be what we should project to our physicians and providers sitting in front of them, so that they pay attention to it. That combination is not a common combination to hear.
So given this link, should diabetes be screened differently or more frequently for pancreatic cancer?
So it would be screened differently for patients with pancreatic cancer. I think what happens is, when someone gets diagnosed with pancreatic cancer, they have to be screened more frequently, number one. With either their finger stick blood sugars, they should be offered a continuous glucose monitor, in my opinion, just because it is so common. 85% individuals with pancreatic cancer are going to have some level of dysglycemia, which is abnormal blood sugars. So they should be offered continuous glucose monitors so that they can monitor their blood sugars and inform their healthcare team that, hey, my sugars are going up, someone needs to intervene. The other thing that we should do for these patients is, or individuals with pancreatic cancer, is that when they come in for their initial evaluation and they have extensive pancreatic cancer, a test is done which is called C-peptide, and insulin test, especially if they're not on insulin. What is their basic pancreatic function? So there are certain blood tests that we can do to determine what is their pancreatic reserve. How much insulin are they able to make on their own? And that helps us determine if this patient needs to be on insulin in the future or right now. So there are certain tests that we can get done at their initial evaluation, and this can be repeated post-op. Especially, I would recommend having these tests done at the time of diagnosis of pancreatic cancer and post-operatively after the surgery has been done to remove their pancreatic cancer, because that also determines how much of pancreas is left behind to release and make insulin. So timing that the test would be very, very relevant.
I was going to ask, are there any, I'm sorry, Cindy, go ahead.
No, I was just going to share also, knowing your family history is really important. So, if you're that 1% of patient that, gets new onset diabetes and has other symptoms like unintentional weight loss or other things that Dr. Shariff is talking about, and you have a family history or a genetic disposition like a BRCA2 mutation, it's even more important that you're familiar with your familial history so that you can get ahead of any potential diagnosis.
I agree with Cindy 100%. I think knowing what's your history, and it has to be a personalized kind of approach. If you know your family history, if you know this is not the norm for you, I think that is something you should advocate for. I always tell my patients, if this is not the norm for you, where you're losing more weight than usual, you're not trying hard enough and you're losing weight, that is not normal. And that's when you have to really put your foot down and say, this is not me, this is not myself, this is not my body, and I know about it. And I think that's when people pay attention to it, if they are not already paying attention to it.
Yeah, sometimes it's difficult though. I mean, you're paying attention because, like you say, you know your body better than anybody else. But getting the doctor to listen and pay attention is what, a lot of us run into. It's like hitting our head against the wall. So I don't know if there's, a magic way that people can get their doctors to listen more, or they just keep being persistent.
I think it's how you package the information is also very important, because I sit on the other side, so I can tell you this, that, in a busy clinic with like 20 minutes or 30 minutes, especially in a primary care doctor's office, right? You're not coming to an endocrinologist on the day one. We pay a lot of attention to this because we do this for a living, right? But when you're going to a busy primary care office in a 20-minute return visit, it's hard to kind of package these symptoms and with the other 10 other things that are probably they have to address during that visit. So it's important to package it in a way that it makes a lot of sense for the person sitting in front of you to be like, this is something I need to worry about. And as I mentioned, losing weight, not doing anything differently, eating less food, and your A1C is going up and you're losing weight, I think that is something that really needs attention. If someone said that to me, I'd be like, hold on, let's talk about this, right? That's when people pay attention. So if folks are having that combination of symptoms, it would be really important to package it that way.
Good. And then how do the diabetic medications impact pancreatic cancer risk or treatment outcomes, or do they?
We haven't really had a lot of studies to showcase that there are certain groups of medication. Now, these are correlational studies more so than causative studies. And when I say correlational, it means that patients, as you know already that I've mentioned, people with diabetes also get pancreatic cancer, and people with pancreatic cancer also get diabetes. So there's a lot of combination medications that patients get. So we don't really have a causation link, which means that this drug can cause pancreatic cancer. It's more of a correlational, where people with pancreatic cancer were also on this medication. So we don't have clear genesis data or clear correlational causative data between the two categories of drugs, but we don't really think that there is a strong association with a particular drug category with developing pancreatic cancer.
So does blood sugar management play a role in either the development or treatment of pancreatic cancer?
So there is a very intricate pathway, which is called the insulin signaling pathway, that is commonly associated with most cancers developing. So this insulin signaling pathway is a growth pathway where sugar comes in, it touches the cell, insulin opens up the doors, allows the sugar to come in, and it activates a ton of growth signaling or growth pathways within that cell. That is the same pathway that cancer cells actually use to grow. So this is why people with diabetes have a stronger link to different kinds of cancers, not just pancreatic cancer. There's other malignancies that are commonly associated with diabetes as well. And there's also a link between obesity, insulin resistance, metabolic disease, and different types of cancers for this reason. So managing your blood sugars and managing your metabolic health does not feed the pathway that allows cancer cells to grow on it. So that's the link between why managing your blood sugars is so important for the genesis of cancer in general. And once you develop pancreatic cancer and you develop diabetes as a consequence, you become very symptomatic in the sense fatigue, weight loss, frequent urination, blurry vision. These are symptoms, and lowered pain threshold. That means patients feel more pain when they have higher blood sugars. These are things that are commonly associated with high blood sugar. So it's important from a quality of life perspective, and from a short-term complication and a long-term complication perspective, the diabetes should be managed appropriately in individuals with pancreatic cancer.
Cindy, what challenges do patients face in assessing new treatments or getting an earlier diagnosis? And what does Let's Win help to overcome these barriers?
So, I think some of the challenges are that patients are unaware of the symptoms that they should be looking out for. I mean, a lot of the symptoms for pancreatic cancer, as we know, are common to a lot of other things. So I think in just the general population, when you have stomach pain or back pain, or things of that nature, people don't jump to pancreatic cancer. I think by the time someone is jaundice and their skin, the yellowing of the skin, that screams out that there's something truly wrong. But often at that point, it's late stage cancer. So I think, it's really, really important. And we spend a lot of time focused on raising awareness to those populations that are at the highest of risk so that they can have the best outcomes and get to the best specialists to get the best treatment options early on.
And how can patients and caregivers use Let's Win to stay informed and to take more active role in their treatment journey?
So Let's Win is now, we were born in 2016, and we have over 900 medically vetted resources in both English and Spanish. And our goal is simple. It's just to be that go-to resource for families at any stage of the journey. So as I've been talking about, in raising awareness of risks and symptoms, but also with respect to recently diagnosed patients, those in treatment or those living with the disease, we have a wealth of information online that's available, to everybody. And like I said, it's also in Spanish, which is great.
Yes, I've looked at the website, both English, obviously, but Spanish too, and I was very, very impressed on how well you guys handled that. And I always recommend anybody who needs it in Spanish to go to your website because it's really amazing what you've done. So thank you for doing that and reaching out to the Hispanic community in that way. I appreciate that. Dr. Shariff, are there any promising clinical trials or research advancements that can change how we approach pancreatic cancer screening for those with diabetes?
Not from a screening perspective, right? There are molecular testing that folks are doing, but I don't think anything is validated and downstream to the level that it is predictive with great accuracy, because that's the tool that we want. We want something that is predictive, that is very accurate, that is easily affordable, and then it gets included in the general screening process. Unfortunately, because of the fact that pancreatic cancer sneaks in at you, and folks are unfortunately quite advanced at the time that they get diagnosed, it is something that is still under study right now. I don't think we have a great tool. We have tools, but I don't think they're highly implemented and heavily implemented in general practice.
And Cindy, we've talked about the website, but how does Let's Win help patients navigate clinical trials and access to new treatments?
So 2 new features that Let's Win added in the last couple of months. One is a trial finder that we help patients navigate to find a trial that's right for them. Either they can navigate themselves, they can be led through a series of questions, or they could work directly with a trial navigator. We think that that's going to be game changing for us to get more people enrolled in trials. And the other thing that we have recently added is a doctor finder. Question I get most often is, if someone is living in the middle of the country, and they say, my uncle, my brother, my father is just diagnosed, and how do we find a specialist? We have created a tool that is data-driven based on medical claims data as to who treats the most patients in medical oncology, in radiation oncology, and in surgery. So this is not subjective. This is based on, by county, who sees the most patients. So we think that this is going to be game changing, and it's the first of its kind.
Yeah, I checked
think that's fantastic.
I'm sorry, go ahead, please. No, go
I
ahead.
was so excited to hear that, Cindy. I think this is great. And I think at this point, I think one more thing that needs to be added, in which we were talking about right before this call, is about ONCO endocrinologists who understand endocrine disease and diabetes in cancer patients. I think that would be a great add-on to this, because all those folks who are getting medical management by their med-oncs and surg-oncs, they're going to require some endocrinologists to manage that blood sugar. So I think one plug that I'm going to put in here is Citrus Oncology, because that's what we do. We do virtual management for side effects and comorbidities in patients. And we have a network of endocrinologists all over the country that can provide care for these patients. And they are specialized in endocrine disease and cancer, which is the reason why I started doing this as a co-founder for the company, is that we really want to democratize this approach to side effect care, diabetes management, like in individuals with pancreatic cancer, because their access is so poor. If you think getting med-oncs and getting surgical oncology care is so hard, trying to find an endocrinologist is even harder, and someone who understands side effects from cancer and its treatments, even more harder to get that. So this is why we're kind of bridging that gap. So I think, we should probably talk after this, but this seems like a
Absolutely.
wonderful, marriage of resources, right? It sounds just
Absolutely.
great to see what you're doing.
We will add this, of course, your work at Citrus to the Diabetes and Pancreatic Cancer section of our site to help more patients. So thank you for what you're doing.
And thank you for the plug. And can you give us that website that people can go to?
So letswinpc.org, and you can find all the information in English and Spanish.
And for Citrus Oncology, it is citrusoncology.com.
Any last minute thoughts? Unfortunately, time seems to go so quickly, so any last minute advice or thoughts that you'd like to share with us, either both of you?
I think I'm just going to add over here that pancreatic cancer and diabetes is just intertwined with each other. And if someone is being diagnosed with pancreatic cancer, you should raise concerns about who is monitoring my blood sugars, do they need to be monitored, and who do I need to see to get this taken care of. And unfortunately, even though we all want to limit the number of physicians and providers we're seeing, this is the kind of diabetes that really deserves to see an endocrinologist. It is not the run-of-the-mill diabetes that a lot of people are comfortable and are equipped to manage. This is a very sophisticated kind of diabetes that really requires a high skill set to manage.
Thank you, Cindy.
Yeah, I mean, just visit Let's Win and take advantage of all the resources so that you could really empower yourself and have just the information to advocate for yourself and get the best treatment.
Thank you both for coming. I really do appreciate it. And I know we're going to continue this conversation. We're looking at doing something in the month of May. So hopefully we will enjoy having you both back and look forward to it. So thank you both very much. I do appreciate your time. Thank you.
Thank you.
Thank you for having us.
As long as you speak my name, I shall live forever is dedicated to Dino Murphy. Thank you.
Thank you.
Well, there you have it. More reasons to tune in each and every time to Living Hope, our weekly journey where we talk about real people, what they're really going through as they embark on this journey with pancreatic cancer. And if you have something you want to know about or real life stories you want to share, please contact us. And if you'd like more information, just go to letswinpc.org. One of many places to find out what's happening in the community. Thanks so much for joining us. Hope you'll join us again and share this information with others as we share it with you here on our Orange County's only community radio station, OC Talk Radio, streaming live from our studios here at the University of California, Irvine's Beale Applied Innovation Center.